Welcome. Today we're talking about heart failure, diastolic versus systolic heart failure.
Ooh, this is one of those topics that was so lost on me. I don't know, I just don't feel like I really understood it in nursing school.
No.
And I remember it wasn't until I was in the ICU that my favorite, guys, I know some of you are going to be here. Can you just please let him know he's like my favorite attending of all time? My favorite Czechoslovakian attending.
The best.
He was just like so good at explaining this. And I was like, I just remember being kind of dumbfounded when he's like, it's diastolic heart failure. It's impaired relaxation. And then he's explaining to me like why we just manage it completely opposite. And I remember thinking, duh, like why did that not dawn on me before? Why did no one take the time to just explain it?
Those aha moments are so wild and they happen so frequently as a new nurse.
Yeah.
So really quick aside, every time you have an aha moment, honestly write it down or do a little bullet journal about it, because you're gonna look back at what you learned over the last year. And it's cool to just see kind of how far you've come.
Yeah.
That's an aside, but as we dive into it, my name is Anna. I am a travel nurse in first year SRNA, student registered nurse anesthetist.
I'm Chrissy, I'm a CRNA, and together we have Confident Care Academy. So welcome to the CCA podcast / YouTube channel. Confident Care Academy is a comprehensive one-stop resource for critical care nurses. So I would love it if you guys would subscribe, follow along. We have lots of good topics that we get into here on the podcast. And then, we have our website, I'm just saying, confidentcareacademy.com, where we have lots more resources up there for you guys.
Come join us in the membership. But yeah, diastolic versus systolic heart failure. I feel like in nursing school, Chrissy has, and I love this because now I think about it every time that I walk into work, but it was one of those sayings. Like heart failure, the way it was taught was like, pink puffer and blue bloater. Like that's how heart failure was taught, honestly.
I think that pink puffer blue bloaters was that for COPD? Either way, the point of this conversation is, I hate analogies like that.
And the other point is that Anna needs a coffee.
No, I know what you mean though. Like the point is that like a lot of times in nursing school, you're right. Like people use
like
cute
sound bites, kind of.
Yeah, cute little sound bites, cartoons, like silly little memorization hacks that like you spend more time learning the hack than it would have taken you to just understanding the concept in the first place.
And the anatomy.
And then, and the anatomy. And then like years later, you go back and you're like, which one was which again? Like what was the mnemonic? Like that's not a good learning tool then. Like if you're like have to recall the tool more than the concept itself, that's not a good learning tool.
Especially for the heart, because the heart makes sense. The heart is a pump and the vessels are pipes. And so if there is an issue with either the pipes or the pumps, you just have to think about where the issue is, take a couple steps back and then figure out how to fix it. The heart makes sense. And I'm not a huge fan of the like mnemonics for specifically in relation to the heart. And there's also a reason that we're teaching heart failure as the third month of cardiac. Of course, we do 3 months in cardiac in our membership. We love the heart. I feel like the heart is also foundational to understanding a lot of the rest of it.
It's foundational to understanding everything else. It really is. Because when we get into like hemorrhage and like when we get into sepsis and stuff, like the heart
factors.
The heart's always gonna, this whole system's always gonna be important to understand the foundation of.
Receptor sites. You can't really talk about management of sepsis before you talk about like alpha 1, alpha 2, beta 1, beta 2. So
exactly.
Heart failure is the same way. So the last couple of months we did in our new to ICU membership, we had months about the anatomy and physiology of the heart. We had a month about the electrical conductivity system within the heart, and then the receptor sites and the sympathetic and parasympathetic nervous system. So all of that kind of builds together to heart failure, because heart failure is all of these things together going wrong in some sort of ways. And you kind of need to know about like the anatomy before we talk about heart failure. But I feel like this is kind of anatomy of heart failure in a way.
It kind of is. So, one thing that I mentioned in the beginning of this video, right, how it was lost on me that diastolic heart failure was so different than systolic. And some of you might be listening and being like,
what's that?
Oh, give it a little squint there, which is cool. It's a good thing. The wheels are turning. We love that for you. So moving back on to diastolic versus systolic heart failure. One of the most important way to like wind it back and think about it is going back to the anatomy of the heart, right? We said in other episodes, like, picturing it, drawing it out, understanding that it's a pump, and like quick review, right? So blood enters right atria. Oof, guys, coffee time. Blood enters right atria, goes through tricuspid valve, goes to right ventricle. This is kind of a low flow, low resistance system in theory in a healthy patient, right? So it only has to work hard enough to pump blood out to the pulmonary arteries, which brings blood to the lungs. They come back through the pulmonary veins, dump back into the left side of the heart, the left atria, through the what? Mitral valve, into the left ventricle, which goes through the aortic valve. Oh, I forgot the pulmonic valve is in there anyway.
Which is high pressure.
High pressure system, right? Like overcoming the afterload, which is like the tone in the system, pushing it out to the body. Ooh, afterload. All these things matter to like review the basics, right?
Yes.
So you think about what those muscles look like. The RV is like kind of like weak and thin, so it doesn't normally have to work that hard. The LV is already like a thick muscle. And over time, for patients with long-standing hypertension, if it has to work really hard to overcome a really high afterload, or a patient with aortic valve stenosis, another form of really high afterload, a really, really tiny hole to go through instead of a nice open gate, nice open doorway, then that left ventricle will have to work harder and harder and harder over time.
Which causes changes to the left ventricle.
Yeah. So what happens if you're like a bodybuilder and you go to the gym every day and you're like lifting heavier and heavier weights? You get swole, you get pumped, right? Your muscles,
you get muscular hypertrophy.
They hypertrophy, exactly. So that left ventricle, the cavity itself gets smaller because the muscle starts taking up more space.
Yeah.
So what happens when the cavity gets too small? You actually lose the ability to deliver enough cardiac output because you don't have enough volume in the cavity.
Yep.
So, these patients really don't tolerate tachycardia because they need as much filling time as possible so that they get enough volume out with each cardiac cycle, with each pump, with each squeeze.
And I will flash above, the cardiac output is stroke volume times heart rate. So if you have a stroke volume that's impeded by the size of the left ventricle, it's not filling enough, you're gonna not get enough blood out. So if they are tachycardic, the cardiac output's gonna go down even more because they don't have adequate filling because of the left ventricular hypertrophy, meaning the muscle is too large, it's not getting enough blood in the LV, and then it's squeezing faster. All of that tanks your cardiac output. Exactly. So it's helpful to think about like, okay, that's a type of heart failure.
That's a type of diastolic heart failure. Yeah. So they're failing in diastole. There's not enough filling time. That's why it's called diastolic, right? The filling time is the part that's failing because there's not enough space because there's so much hypertrophy. Yep. So these patients need beta blockade to keep the heart rate nice and slow. Usually nurses, we think about heart failure, we're like, no fluid. This patient actually could probably tolerate fluid and actually probably needs the fluid. So this is like, preload is gonna really help them out a lot.
Because what's the problem? At what point in the pump is there a problem?
Yeah.
Is it right-sided heart failure? No. Is it pulmonary hypertension? No. At this point, the issue is that the left yeah. So at this point, the issue is that the left ventricle has become hypertrophied. The muscle's taken up too much space in there, so there's not enough room to fill it with blood to get enough of the squeeze out to the rest of the body. How can you help that? You can make sure that the heart rate's not going to go too fast, and you can make sure there's like enough preload coming in. So fluids and beta blockers.
Yeah, fluids, beta blockers.
I love the heart.
We love it. It makes so much sense when you just slow down and draw it out. Mm-hmm. And then the opposite is true for our patients with cardiomyopathy. It's like the exact opposite problem, especially like a dilated cardiomyopathy. Actually, I shouldn't say cardiomyopathy. There's hypertrophic and there's dilated. So the hypertrophic is more in line with what we were just talking about, the diastolic heart failure, the impaired filling. The dilated cardiomyopathy is the opposite, and that's the heart failure that I think comes to most people's minds.
You typically think left-sided heart failure, you think dilated cardiomyopathy. It's more common, right? Isn't it more common?
I don't know. I gotta look that up. I actually have no idea. I mean, we see patients with.
We'll fact check ourselves.
I'm not sure because aortic stenosis patients always have some degree of diastolic impairment.
Yeah.
And I think it's just like underrated and under talked about. And I think that like it has to be pretty severe before it gets to the point of like heart failure as a result. Those are like the Hokum patients a lot of the times.
Yeah.
But usually like it's being caused by like either long-standing hypertension, it's kind of mild and like can be managed. Like if your patient's being medically managed with antihypertensives, and beta blockers, they should be okay.
So you look it up and comment below which one's more common.
Yeah, I don't know.
That'd be great.
Yeah, I was gonna say I think it's like more like the severity, right? Like seeing severe enough diastolic heart failure
for impaired function.
That's like also it's harder to quantify because guys, this is more point. Something that's often lost in this conversation is that the ejection fraction is going to be normal, or here's another fancy buzzword for you, hyperdynamic. It's actually going to be greater than normal because the heart muscle is so strong and so good at pumping, it's going to over-eject with each cycle. So instead of an ejection fraction of pumping out 55 to 65% of the blood volume each cardiac cycle, that's what it should be, right? Like
a normal.
A little more than half the
fraction.
blood should be pumped out with each cycle. There should be a little left over. It's going to pump out like 75%, 85%. 85 would be really bad, but you know, we don't want to overeat our blood.
Doing too much, doing way too much.
These patients also are not going to necessarily benefit from something like epinephrine. So, you know, these patients
Wouldn't benefit from something like epi.
they wouldn't benefit from something like that, epi. That's going to make the heart squeeze harder. It's going to make more contractility. So again, that goes back to our video linked above about understanding your pressor, what they do, what receptor sites they work on. There's all kind of links together, right?
Right.
Opposite is true for your dilated cardiomyopathy patients.
Cardiomyopathy. They need so dilated cardiomyopathy. Your LV is dilated out. It's not doing a great job squeezing and contracting. So if it's not doing the best job squeezing and contracting, what can you do as the nurse or as the medical team to improve forward flow? Adding on inotropes is a good choice. A lot of times you'll see epi or dobutamine, I find often a lot of places. You're going to increase the inotropy, the squeeze of the contractility of the myocytes through calcium, which is all in the membership and in this other video. Anyway, all that being said, you're going to increase the contractility to increase forward flow, and that heart needs a little bit of extra support to get the blood moving back forward the way it's supposed to be.
Yeah, not just that, like when these patients, like you said, dobutamine, it's a great drug because it's going to increase the inotropy, increase the squeeze, the contractility, help the heart pump more effectively. It's also going to do what to the afterload? It decreases the afterload. It brings down the blood pressure, which is kind of counterintuitive to a new nurse. You're like, why would I want my patient with heart failure to have a low blood pressure? Isn't low blood pressure bad? Well, in this case, decreasing the afterload is going to be really helpful at decreasing the workload of what it has to overcome to squeeze. It's going to make forward flow easier.
The heart is not only squeezing, it's also squeezing up against a little bit of pressure from the vessels. So if you're decreasing the afterload, you're making it easier for the heart to pump forward, which is sepsis. We're going to talk about this later. You have really dilated out, like you have very low systemic vascular resistance during sepsis because the vessels are dilated and the heart's pumping against no resistance, basically. So in this situation, this patient has a dilated left ventricle. You want to make the ventricle squeeze harder, and you also want to decrease the afterload so that the forward flow. Dilated cardiomyopathy is the opposite in management of the hypertrophic cardiomyopathy. So what's happening in the heart? What's happening in the pump? At that point, instead of the left ventricle having all of this extra muscle, it is dilated out and it is not squeezing very effectively. So you have a very weak and flimsy left ventricle. What are you going to do from the medical team management side for that? You're going to want to make the heart squeeze harder, and how are you going to do that? With inotropes. So this is where you're going to add on your epinephrine, potentially your dobutamine, things that are going to increase inotropy and to a certain extent chronotropy as well, the rate. And then the decreasing dobutamine is really good, decreasing the afterload as well, so that the heart is not pumping up against a wall. It's pumping up against a nice open blood vessel for forward flow. It's all about forward flow.
All about the forward flow.
Where is the issue with the forward flow? That's always the question.
Exactly. So in this case, it's a pump failure.
Yes.
These patients you also might see on home milrinone. That's another really common thing that they'll come in with. You'll usually just continue the rate in the hospital. Sometimes they might need milrinone loads or boluses like in the OR before surgery. I feel like where I work now, we almost never milrinone load people, but where I trained, we kind of did it a lot, which is interesting. I don't know if what the evidence is behind that. I gotta dig a little
milrinone is
deeper.
such an interesting medication.
It is.
We talk about this in the membership, which is linked down below. But the phosphodiesterase inhibitors, it's kind of an inodilator a little bit.
Ooh, what a spicy term.
It's so exciting. We're just such nerds. But increases forward flow, increases inotropy, and also can have some dilation effects in the coronaries, which is nice for coronary perfusion. Anyway, so yeah, these are patients that might be on milrinone at home long term. Fun fact about milrinone, it takes forever to get out of the patient's system. So you're gonna.
That's true. It's got a really long half-life.
Yeah, you titrate that guy real slowly. Or you wait to see the effects. Consult a provider near you about changes.
Yeah, that's a drip that's typically not nurse-driven, the rate changes.
It's usually provider managed.
Yeah,
Yeah.
which makes sense because it's kind of like,
It's really long half-life.
yeah, it's longer to see the effects.
And then
it's
if
a
they're
little less
on it,
common.
they already have a sick heart, so you're
Yeah, these
The
are
providers are
unstable.
usually pretty more on top of these patients anyway.
These are also the patients that may eventually head towards management with VATS. They might get on a heart transplant list.
Yeah.
And, you know, that's like the more traditional heart failure picture again, where so not only do we want a low afterload for them, so it's easier for them to eject the blood, not only are we increasing squeeze with inotropy, we're avoiding excess fluid at all costs. So we want to reduce their preload. Because too much preload for them, usually these patients, if their left ventricle is really already that down, that, you know, sick, they've already experienced that backup of blood into the left atrium. A dilated, stretched out left atrium has what? Usually ends up going into atrial fibrillation.
Which is in this video here, linked here, AFib, and why it happens and how to manage it. Go watch that guy.
They lose that atrial kick, they have even less cardiac output, everything backs up further into the pulmonary arteries, pulmonary hypertension. What happens with pulmonary hypertension eventually causes right heart failure. The right heart is just not able to manage that huge inflow of volume. So, you know, that's when you get that back up into the body, all the venous congestion, liver failure, et cetera,
liver failure, all of the above. Yeah.
All bad things. So these are your patients who like are usually very complex, very sick, very frail, and you really need to be super on top of the fluid management and restricting very much and reducing preload. So that's where other drugs like nitroglycerin come in.
Yeah.
You're reducing the preload for this patient.
Which then
by reducing venous return.
It gets so
By venodilating.
By venodilation. So this is where it gets. I see so many new grads and new ICU nurses who they'll say, "Why are we doing nitro and epi at the same time?" It's just like it's not understanding where the medications work in the body and why you're doing what you're doing.
They are seemingly opposite, right? Why would I give something that brings up the blood pressure at the same time something that brings down the blood pressure?
Yeah.
Well, it's not about the blood pressure, as a matter of fact. It's about enhancing squeeze and reducing the workload of the heart at the same time. So we're giving it a little extra oomph, and we're venodilating, relaxing the blood vessels so that the blood isn't all returned to the heart so quickly.
Yeah.
So that the heart's workload can be reduced. Another fun fact is that CPAP and BiPAP can actually also help offload an acute CHF exacerbation. So an acute heart failure exacerbation.
Pressure, right?
Yeah, that increase in intrathoracic pressure also helps reduce the preload, which is a fun fact.
Decreases like venous return to the heart.
Exactly.
Yeah.
Exactly.
That's a super fun fact.
Super fun fact.
Other fun fact that just came to my mind is a lot of times patients come out the OR after like having a radiograft on nitro and epi and levo.
That was another example I was thinking of, but I was like,
so as a new grad, you're like, why are we on epi and levo and nitroglycerin? These are
on
opposites.
cardipine, either or,
Yeah.
depending on your institution.
Depending on your institution.
But yeah, the reason is because it's going to help, but at least it's a theory. I don't know if it's like been totally like proving it. Let's be
Sometimes
honest.
surgeons do things that are like lore and not necessarily like super evidence-based.
Well, I don't know. Like,
But
it's definitely
could
getting
be.
more popular. So this is something that's actually gaining popularity. So I think that there's
It
some
makes
evidence
sense.
for it.
It
And it makes sense logically.
Totally.
And we're not even telling you what it is. I hope you're on the edge of your seat right now.
Get ready.
I hope you're in suspense. The idea is that it can help prevent coronary artery vasospasm. So, you know, they do these fresh cabbages. The radial artery graft, the radial artery is a smaller artery than the lima, left internal mammary artery. Another common grafting site is the saphenous vein. Fun fact, they actually have to strip the valves out of the veins because veins have valves, arteries don't.
That makes sense, but I never.
They like remount the valves. It's very cute. And
they
then
remount the valves?
They remount the valves. They shove a big metal rod through the vein and like remount the valves, and then they squeeze heparinized saline through it and like look for leaks. And then they'll like repair the leaks or trim the sites and then like keep squeezing it through.
Whoa.
It's like really fun to watch.
She's a cardiac CRNA, so she sees all these cool stuff.
Was RRNA. Anyway,
She started a new job.
starting
in
a
New
new
York
job.
City.
I had to give it up. But I'm a city girl now, so it's okay.
And now
Anyway,
you're dating back with being a little bit of Pete's, so
I'm terrified of pizza. Anyway, let's keep
that's an aside.
So, main point is the radial artery is a small artery. It's not that big. It's not a big boy. So it's at risk for spasm. And if you have a fresh graft site to a heart that's an ischemic heart, right? That's why they're getting a coronary artery bypass in the first place. You're trying to increase blood flow to the heart, increase perfusion to the heart. And then you sew on a skinny artery and then it spasms, you're cutting off your fresh blood flow to the heart. That's no good, especially after surgery. The heart's a little extra cranky.
Yep.
And then you're gonna cut off its new fresh blood flow, it's not gonna be happy with you. So it's
do
really
a little sprinkle in some low dose
a little
nitro.
sprinkle of nitro or nicardipine theory helps reduce the risk of that new graft spasming.
Yep. And this is something that I was talking to Chrissy about like last month, is that I didn't understand the why behind that. I thought that they did the low dose nitro to prevent vasospasm at like the ulnar level, because you would just remove some of the radial, which is not, I mean, like,
It makes sense why you would think that.
but it's not the whole thing, which is the whole thing is ask a lot of questions. Be like, oh, so like, why are we on both of these at the same time? Well, like this is, it seems a little bit counterintuitive. So ask a lot of questions, and then also just understanding what your medications do, because thinking just in terms of blood pressure is not the whole picture for ICU.
Blood pressure is not the picture.
Yeah, so a lot of medications you're giving, you're like, oh, okay, well, then you could say that epi and vaso and neo and levo and dobutamine are all for blood pressure.
They're all for squeeze and pressure.
They're all for squeeze, but that loses so much of the actually why you're giving the medication.
Yeah.
Which then gets into the whole like, oh, well, you see a patient who was on like inotropes, but then also a beta blocker. And if you're thinking that a beta blocker is for blood pressure, you would be wrong, because that's not why you're using that medication.
Yeah.
All that said, it's really important as a new grad to circle back over and over again to the receptor sites, like alpha 1, beta 1, beta 2, alpha 2, like, and like the dopamine, dobutamine, and vaso. So like, where does it work and why are you giving it?
Yeah, and understanding like, not only where does it work, why you're giving it, but just like, I don't know, I'm just gonna repeat exactly what you said, just reviewing it over and over in your head until it just becomes like intuitive, like in-depth, natural knowledge to you. Like get it from the level where you have to retrieve the information from your brain into it just becoming second nature, where you can just picture it, because it's gonna help you understand concepts more, it's gonna help you understand heart failure more, it's gonna help you manage your drugs more, and then when you get patients that aren't familiar to you, you're going to be able to have a 5-second diet explanation of their disease process or the drug that they're on. And with your constellation of other knowledge, you'll be able to put the rest of the picture together.
It fits into place. Yeah, absolutely. And then I have a video here, you can link to here, about science-based study tips and how to do spaced interval repetition learning for memorizing your inotropes and your medications, your drugs.
So good.
All of your nursing students. It was written for nursing students about how to memorize for exams, but this is also how you're going to study as a new ICU nurse, because you need to do spaced repetition learning for your medications so that it becomes from short-term memory to long-term. Then it becomes something that you operate off of. You have to move quickly is the thing in the ICU. So you need to know what your medication is and what dose you're giving it and all of the receptor sites and where it's working, so that
inside and out,
so that you can hang it up, throw it up there, titrate quickly, because your patient's kind of need for you.
Also, so that when you're on night shift and the person who's responsible for managing your patient is an intern or second year surgical resident, that you will be able to make suggestions, because maybe they're not familiar with that patient population either. Even though they're very smart people and they've studied a lot, that is not necessarily their wheelhouse if they're just rotating through. So you can make appropriate suggestions when your senior nurses are tied up in an emergency, for
based off
example.
of your patient population, which is totally appropriate as an intern has, 1 month surgery rotation, a couple of months IM. They're rotating through and they just got there. So totally appropriate to dialogue about that.
Yeah, and then you'll be able to keep up and ask questions and just understand what you're doing more.
And about that, anytime that there is an attending doing like a chalk talk, like teaching the residents, if your patient is right next to where they're doing the education and you can listen.
Absolutely. Any opportunity you get for that stuff is, going to be phenomenal for you. And just pulling people aside and saying, for my learning, for my understanding.
That's key.
So key, so clutch. It's going to make the biggest difference in you really getting what's going on or not. Again, favorite attending of all time. My favorite Czechoslovakian attending. I should say Czech is not Czech Republic and Czechoslovakia are two different countries, and I'm aware of that, guys. I know, but anyway. At the time, it was one country when he immigrated here. Okay.
Still her favorite physician.
He's still her favorite physician. And, I used to do that. I was actually scared of him when I was a new nurse. I thought he was mean. And then I realized he's actually not mean. He's phenomenal. And then I would pick his brain and ask questions. And I still do it in the cardiac hours with him. And I'll be like, can you draw that? I still don't understand what the heck you're talking about. It's the 8th time I'm asking this question. Can you help me?
Can you walk me through this?
And he does. And guess what? I'm 10 times smarter now. And it's amazing. It's like, just pick people's brains. It's going to help
Soak it all in. Soak
it in.
up all of the
Don't be
knowledge
afraid to look dumb. Don't be afraid to feel dumb.
Yeah.
You also don't have to be self-deprecating, but for my learning, for my understanding is like the number one golden nugget. Your ticket to, accelerating your learning and confidence.
The thing is, I'm a lifelong learner, you're a lifelong learner. You're not going to know everything in your first couple of years as a nurse, and you have no expectation of needing to know everything, but you can put yourself in the position of being a curious learner who wants to know as much as they can about what's happening for their patient population. And that's really what matters at the end of the day, is that you are putting yourself in a position to learn. And we also have, in the new to ICU membership, we are talking about heart failure this month. We also have lots of free YouTube resources for people.
Yes, we have a video up about pressors a little bit. We get into it a little bit with the receptors and pressors, but we go way deeper in the membership. So yeah, please join us there.
So join us there on confidentcareacademy.com and join us here. Comment what you would like us to talk about next time, and we'll see you next time.